Fundamentals of occlusion. In this section, we will discuss definitions, mandibular movement, normal and pathological occlusion, occlusal interferences, schemes of occlusion, and determinations of occlusion. Why occlusion is very important? Because it helps us, it assists us in diagnosis and planning restorative care. We can minimize failure and ensure predictable outcomes by minimizing loads on teeth, managing the environment so that we get a minimal amount of surprises, similar to wearing a car seat belt. The less the patient has to adapt, the better. The definitions. The first is occlusion. This is a relationship between masticatory surfaces of the maxillary and mandibular teeth. It's called a relationship between two contacts and mandibular movements. First, this is centric occlusion on the lower picture. This is a relationship between mandible and maxilla when the teeth are in a maximum occlusal contact, irrespective of the position or alignment of the condyle disc assemblies. The relationship between the maxilla and mandible when the teeth are maximally meshed with the mandible and it's in its most cranial position. Centric relation. This is a relationship of the mandible to the skull, where the condyle is in an anteriorly, superiorly braced position along the articular eminence of the glenoid fossa, with the articular disc interposed between the condyle and eminence. You can fix it during the X-ray procedure. Mandible movements. They occur in three axes. First, this is a horizontal axis, then it's a vertical axis, and sagittal axis. Horizontal axis rotation. This movement occurs in the sagittal plane when the mandible in centric relation makes a purely rotational opening and closing border movement around the transverse horizontal axis, this one, which extends through both condyles. Vertical action, vertical axis rotation. This movement occurs on the horizontal plane when the mandible moves into the lateral excursion. The center for this rotation is a vertical axis extending through the rotation of the working side condyle. And the last one here we can read about working side and balancing side. When you move your jaw, your lower jaw, your mandible, for example, to the right, and your canines fixed together from the lower jaw and upper jaw. You have the right will be working side, this side toward which the mandible moves during excursion, or mandible moving toward the cheek. Working side condyle pivots within the sockets and is better supported. And the second one, this is balancing side. If you move it to the right, this will be the work side and this will be the balancing side. It's so-called non-working side. The side opposite to the direction in which the mandible moves, or mandible moving towards the tongue. A balancing side condyle has a downward orbiting path and is more prone to injury or damage. This is small picture. It's very strange, but it is. You can see this is movement direction. This will be working side, and this will be balanced side. Sagittal axis. This movement occurs when mandible moves to the working side. The condyle to the opposite side, non-working side, travels forward and downward simultaneously. When viewed in the frontal plane, this produces a downward arc on the non-working side, rotating about the anteroposterior sagittal axis, passing through the other condyle. Pure hinge movement. It occurs as the result of the condyle rotating in the lower compartment of the temporomandibular joint within from 10 to 13 degree arc, which creates a 20-25 millimeter separation of the anterior teeth. Translation movement occurs when the mandible moves forward in protrusion. Teeth, condyles, and all move in the same direction and on the same degree. It occurs within the superior cavity of the joint. Maximal opening. Maximal open occurs in the upper compartment of the joint as the mandible drops down further. Then the horizontal axis of rotation shifts to the area of the mandibular foramen as the condyles translate forward and downwards while continuing to rotate. Protrusive position. When the mandible slides forward so that the maxillary and mandibular anterior teeth are in an end-to-end relationship. It is in a protrusive position. This is true for ortognatic bite. When your mandible moves forward. You see. Bennett movement. Bennett angle, Bennett movement. It's defined as the bodily lateral movement, lateral shift of a mandible resulting from movements of condyles along lateral inclines of mandibular fossa during lateral jaw movement. Bennett angle. This angle formed between the sagittal plane and the average path of advancing condyles as viewed in the horizontal plane during lateral mandibular movements. Average range is about from 7.5 to 12.8 degrees. This is Bennett angle, maximum Bennett angle. Posterior determination of occlusion. X-ray is one of the best methods for determination of central occlusion because you can clearly see the position of condyle. This is anterior determination of occlusion. On this picture you can see the coordination of incisors, canines, and premolars and molars. Anterior determination of occlusion, posterior teeth. They provide vertical stops, guide mandible to CO. Anterior teeth guide mandible in protrusive and lateral excursion. The closer the tooth located to a determinant, the more it will be influenced by it. Occlusion and interferences. And then interferences are undesirable occlusal contacts that may produce mandibular deviation during closer to maximum intercuspation and may hinder a smooth passage to and from the intercuspal position. These can be of following types: centric, working, and not working. Centric interferences. The premature contact that occurs when the mandible closes with the condyles in their optimum position in the glenoid fossa. It will cause the flexion of the mandible in a posterior, anterior, and lateral direction. Work inside interference. It occurs when there is a contact between maxillary and mandibular posterior teeth on the same side of the arcs as the direction in which the mandible has moved. If that contact is heavy enough to seclude anterior teeth, this is interference. It's called as an interference. Non-working side. Mm. This is an occlusal contact between maxillary and mandibular teeth on the side of the arcs opposite the direction in which the mandible has moved in a lateral excursion. It has a potential for damage in the teeth, epidial, loam, and MJ due to the changes of the mandibular leverage and the placement of forces outside the long axis of teeth and disruption of the normal muscle function. Protrusive interference. This is premature contact occurring between the major aspects of mandibular posterior teeth and the distal aspects of maxillary posterior teeth. The proximity of the teeth to the muscles and the oblique forces make them potentially destructive. They also interfere with the patient's ability to incise properly. Let's see for coordination between ideal and pathologic occlusion. Ideal occlusion should provide comfort and function in a predictable way. Ideal occlusion at the tooth level, cusp tip to fossa or cusp to marginal ridge contact, non-inclined contacts. Ideal occlusion at articulatory system level, posterior stability, anterior guidance, and lack of posterior interference. And ideal occlusion at the patient's level. Features of ideal occlusion: anterior guidance, and lateral excursions of the mandible work inside, the contacts preferably on the canines, disocclude or separate non-working teeth instantly. In protrusive excursions, anterior tooth contacts will disocclude the posterior teeth. For example, this one, you can see it. This is interference. Features of ideal occlusion: posterior stability, enough posterior teeth in each arc with solid and stable. Contacts in appropriate positions to evenly distribute loads and to allow mandible to close and be reproducible through posterior. Teeth contact more heavily than anterior teeth. Lack of posterior stability. Here you can see it. Then they have a highly reduced height of front crowns. Features of ideal occlusion: the non-working side, and here is good super contacts. Features of ideal occlusion: central occlusion is achieved at the centric relation position. Occlusal loads are actually transmitted through the teeth. Organization of occlusion. There are three recognized concepts that describe how teeth should contact in various mandibular positions. Bilateral balance occlusion, unilateral balance occlusion, group function, and mutually protected occlusion. Bilateral balance occlusion. It dictates that a maximum number of teeth should contact in all excursive positions of the mandible. Use to the complete denture occlusal scheme as the contacts of non-working side prevent tipping of of the dentures, not used for fixed prosthodontics, as very difficult to achieve. Unilateral balanced occlusion, also called root function. It requires teeth on the working side to be in contact in lateral excursion, and teeth on the non-working side are free of any contact. Avoids destructive oblique forces on the non-working side. Prevents wear of maxillary, palatal, and mandibular buccal cusps. Mutually protected occlusion, also called canine protected occlusion. Anterior teeth overlap prevents the posterior teeth from making any contact on either the working or non-working sides during the mandibular excursions. Anterior teeth bear all the load, and the posterior teeth are disoccluded during excursions, protecting the posterior teeth. In central occlusion, posterior teeth direct forces through their long axis, and the anterior teeth are slightly in or out of contact, protecting the anterior teeth. Guidance. Describe the influence past the mandible takes as a result of the contacting surfaces of the teeth. Depending on the contact and the shape of the teeth, they should be in harmony. Protrusive guidance. Influenced part of the mandible takes as a result of forward thrust. Lateral guidance. Canine. I'm sorry. Group function. When lateral excursions are guided by more than one tooth, other than the canines. Hannah squint. By modifying of the following 5 factors, a scheme of occlusion can be developed that will suit a particular patient's best. Condylar guidance, incisal guidance, occlusal plane orientation, compensation curves, and the height of the cusp. Anterior guidance. Guidance produced by the teeth themselves and not the temporomandibular joint, can be on any tooth. The influence of contacting surfaces of anterior teeth on mandibular movements. The influence of contacting surfaces of the guide pin and anterior guide table on the articular movements. The fabrication of the relationship of the anterior teeth and prevent the posterior teeth contacts of all essential parts. Effects of anatomic determination of occlusion. Protrusive incisal path or way. The track of the incisal edges of the mandible mandibular teeth for maximum intercuspation to edge occlusion. Protrusive incisal path angle. The angle formed by the protrusive incisal path and the horizontal reference plane in the protrusive incisal path inclination. It ranges from 50 to 70 degrees and often 5-10 degrees steeper than the sagittal condylar guidance. Incisal guide angle. The angle formed with the horizontal plane of occlusion and the line in the sagittal plane between the incisal edges of maxillary and mandibular central incisors when the teeth are in maximum intercuspation. The angle formed in the sagittal plane between the horizontal plane and the slope of the incisal guide table. The importance of anterior guidance. Opening and closing the mandible is simply rotation of the condyles in the articular fossa. Importance of anterior guidance. Also, it concludes that anterior guidance is normally steeper than the condylar guidance, and the anterior teeth guide the mandible downloads during protrusive or lateral movement, and produces disocclusion or separation of the posterior teeth. Here you can see importance of articular guidance during lateral movement. You can see it can be shoulder contact and this contact when it's group function. Anterior guidance is linked to the combination of horizontal and vertical overlap of the anterior teeth and can affect the occlusal surface morphology of the teeth. Interrelationship with vertical and horizontal overlap of the anterior teeth. Anterior guidance can be steeper by either increasing the vertical overlap over bite AB or by reducing the horizontal overlap over jet CA of the anterior teeth. Anterior guidance can be made shallow by either decreasing the over bite BA and or increasing the over jet ATC of the anterior teeth. Condylar guidance and posterior tooth morphology without considering the role of AG. Condylar guidance normally requires shallow cusp angle or short cusp height, and steeper condylar guidance requires cusp angle or no longer cusp height. Condylar side shift and posterior tooth morphology without considering the role of AG. You see side shift plus and side shift minus. Okay. Similarly, in the presence of immediate lateral side shift during lateral movement, Bennett's movement. The cusp height and the cusp angle should be shallow. This is the influence of guidance of anterior guidance on posterior tooth morphology. It depends on one point or several point contacts. Influence on the posterior tooth morphology. This is greater overbite produces more disocclusion and hence permits longer cusp height. Less overbite, less disocclusion, shorter cusp height. You see, if you have a big way, this way, disocclusion will be more on this one, and so you have cusps more loose, I think, yes. And if your path is less, this will be less place for disocclusion. Influence of the G on posterior tooth morphology. Summarizing, greater anterior guidance allows posterior teeth to have a longer cusp height, and smaller anterior guidance, as you saw on the previous picture, requires posterior teeth to have shorter cusp height. This one, so-called. By increasing the anterior guidance angle. To compensate for inadequate or shallow condylar guidance, it's possible to increase the cusp height of the posterior tooth, or teeth, sorry. Similarly, increasing the anterior guidance will permit lengthening of the cusp that otherwise have to be shorter in the presence of pronounced immediate lateral translation of the condyles. Jaw movement. Wow. Yes. On this picture, this GIF, I think, you can see that when you open your mouth, this is a symmetrical middle line between central incisors of upper jaw and of the lower jaw. It's not absolutely plain. Yes? It's not absolutely не прямая, да? When you open your mouth, your mandibular, your lower jaw, uh, how the following movement, so-called S line, S line. This is the spousal figure, so-called, because like all monkeys, we have three freedom planes in our temporomandibular joint. Spousal figure. Here you can see it. I will not describe it. You will all this. You will check in our textbook. I'll show you items, and I'll tell you what pages will you check, will you read. Articulators. Articulator, this is a mechanical representation of the jaws and temporomandibular movement, joint movement, so-called. When do you use them? You will use them for diagnosis, slides and occlusal relationships, for treatment planning, diagnostic wax-up, occlusal adjustment, fabrication of splint prostheses. Articulators, here four types of articulators. Here, simple hinge, average value, semi-adjustable, fully adjustable. You can see this one. Cast holder, this is the most simple. I think who was in Russia, if you were in Russia already on the first year of education, have already saw similar, not this one, but similar articulators and use them. This is articulator Bandil. He was the inventor of it. 4 inches. Do you know this is the type of articulator, say non-Arcan, not Arcan, then NR2, and this is a semi-adjustable, one of the most complicated articulator. We can define TMJ way. We can define Bennett angle. We can define incisional guidance play. It's very important when you're going to make total prosthetic work. You need to record Facebook, to record your lower jaw movement. You need the transfer fork, so-called transfer fork, to use it. So-called, yes, this one. Also, we can have a third point of fixation. But if something is wrong with your patient's teeth rows, you need to make them parallel to the all cranial. And this point, and this point, and this point, they make you to do a good work. Fully adjustable. This is the most fine articulator. Again, posterior wall, superior wall, medial wall, inclination of superior wall, condylar angle, intercondylar distance. What if patient doesn't match articulator? Therefore, the distance from the condyle to the teeth is crucial. We obtain the measurement of the distance with a face bow. You can also this one. This one. You have this device in your clinic. You make a small impression. This is not. I can show you it in clinic. This is not an impression. This is not an impression. And if your upper tooth row is not parallel cranium, then, for example, it looks like that. Then you will have a big amount of impression mass here and a very little amount of impression material here, just like that. In this case, you see it's quite parallel. Anterior GG. This is a cold cure acrylic, a green stick. You can fix it. For example, this is anterior position. It's clinically useful settings for articular condylar angle at sagittal plane is 30 and lateral guidance is 15 degrees. Immediate side shift 0.3 millimeters, and progressive side shift is 6 degrees. Incisional guidance stable. Allows shape of palatal to be reproduced and allows length of incisors to be maintained. So called, you can say it. What's the next? Here is it. They're absolutely congruent. You see? According to the results of articulation, you're going to prepare your patient's teeth. Here it is. Here you can see tooth form reconstructed. Okay, summary. The choice of articular depends upon such factors as intended use, skill of the technician, availability of equipment, expense, patient's occlusion, and skill of the operator. The more closely the articulator matches the patient's anatomy, usually the better the outcome and the less adjustment the requires or chair side or fitting processes. No articular is best, and no one can record all jaw's movement. Articulator can try to record only jaw movements, not reproduced anatomy of joint. Now, if you have any question, this theme is very complicated, I think. It's not very clear for everybody. If you need to ask questions, you can send them to WhatsApp chat. And I insist that we will be very glad to see you soon in Russia because it's very difficult to explain articulation and occlusion online. It's absolutely impossible. So, bye bye. See you soon.